Dear students, in this semester we will learn about endodontic treatment. Before endodontic treatment, we should know about structure of endodontic organs. Firstly, about structure of pulp. Pulp is a connective tissue and located inside of teeth. There are two parts of pulp: crown part and root part. Pulp is a connective tissue and consists of grown substance, fibers, odontoblast cells, fibroblasts, mesenchymal cells, defense cells, blood vessels, lymph vessels, nerves, and nerve endings. Grown substance. Grown substance consists of glucosaminoGlycans and glycoproteins and water. Function of grown substance forms the bulk of the pulp, supports the cells, acts as a medium for transport of nutrients from the vascularate to the cells and metabolites from the cells to the vasculate. Collagen fibers. This is called also the fibrous matrix. Fibrous matrix collagen fibers type 1 and 2 are present in an unbundled and randomly dispersed fashion, higher in density, around blood vessels and nerves. Type 1 collagen is thought to be produced by the odontoblast as dentin, secreted by these cells, is composed of type 1 collagen. Type 2 is probably produced by the pulp fibroblasts, as this type increases in frequently with the age of the tooth. Older pulp contains more collagen of both the bundles and the diffuse types. Fibroblasts. Fibroblasts, they are star-like cells with ovoid nucleus. The greatest number in the dental pulp, particularly in the cell-rich zone. Their function is to form and maintain the pulp matrix. They also eliminate excess collagen. Odontoblast cells, the main cells for dentin. Odontoblast cells have body and processes. The processes of odontoblast cells finished inside of dentin canals. Function of odontoblast cells to aid in the secretion of the intertubular and peritubular dentin that forms the dentinal tubule, which further organizes and strengthens the dentin as a wall. General maintenance of both the dentinal tubule and the dentinal fluid to channel hydroxykinetic forces of water movement to the A delta fiber wrapped around its base, maintaining its sensitivity. To secrete sclerotic dentin upon carious attack, to block of dentinal tubules, slowing the progress of the attack, to channel signals of attack to the odontoblastic cell body, thus initiating secretion of reactionary dentin. The odontoblasts secrete the dentin throughout their life, unlike enamel, which they consider secondary dentin once through formation of complete, which may be an attempt. Mesenchymal cell. Mesenchymal cells, they are smaller than fibroblasts, but have a similar appearance. They are usually found along the walls of the blood vessels. The cells have the potential of forming other types of formative and defensive connective tissue cells. Defense cells in pulp, we can find a lot of defense cells as monocyte, eosinophils, basophils, plasma cells, macrophage, mast cells, neutrophils, lymphocytes. But sometimes we can't find because these kinds of defense cells migrate in the organism. That's why when there is inflammation of pulp, we can find all of them, all types of defense cells. Blood vessels. The walls of pulpal vessels are very thin as the pulp are protected by a hard unloading sheet of dentin. One or more small arterioles enter the pulp where the apical foramen and ascend through the radicular pulp of the root canal. Once they reach the pulp chamber in the crown, they branch out periphecally to form a dense capillary network immediately under and sometimes extending up into the odontoblast layer. The capillaries exhibit numerous pores reflecting the metabolic activity of the odontoblast layer. Small veins drain the capillary and eventually leaves the venous via the apical foramen. Nerve fibers or innervation of pulp. There are two types of nerve fibers, autonomic and afferent or sensory nerve endings. Autonomic, only sympathetic autonomic fibers are found in the pulp. These fibers extend from the nerves, bones, cells, bodies, and are found in the superior cervical ganglion at the base of the skull. They are unmyelinated fibers and travel with the blood vessels. They innervate the smooth muscle cells and the arterioles, and therefore function is a regulation of blood flow in the capillary network. Afferent fibers arise from the maxillary and the mandibular branches of the fifth cranial nerve, trigeminal nerve. They are predominantly myelinated fibers and may terminate in the central part. From this region, some will send out small individual fibers that form the subodontoblastic plexus of Rashkov, just under the odontoblast layer. From the plexus, the fibers extend in an unmyelinated from toward to odontoblastic, where they then lose their Schwann cell sheath. The fibers terminate as free nerve endings near the odontoblast, extend up between them, or may even extend further up for short distance into the dentinal tubule. They function in transmitting pain stimuli from heat, cold, or pressure. The subodontoblastic plexus is primarily located in the roof and lateral walls of the coronal pulp. It's less developed in the root canals. Few nerve endings are found among the odontoblasts of the root. Lymph system, the same with arterial or venous system, and lymph system drainage to the neck nodes of lymphatic system. About layers, there are 4 layers inside of pulp. First, odontoblast zone or odontoblast layer. Second, cell-free zone. Third, cell-rich zone, and last one, the pulp core. In odontoblast layer, there are odontoblast cells and dendritic cells. Cell-free zone consists of fibers, blood vessels, and Rashkov plexus. Cell-rich zone, there are a lot of cells as fibroblasts, mesenchymal cells, macrophages, lymphocytes, plasma cells, mast cells, and in pulp core there are ground substance, fibers, nerves and vessels, and a little bit fibroblasts. Functions of dental pulp. 4 functions of dental pulp: nutrition, sensory, formative, protective. Nutrition, blood supply for pulp and dentin. Sensory, change in temperature, vibration, and chemical that affect the dentin. Formative, the pulp involved in the support, maintenance, and continued formation of dentin. And last one, protective, development and formation of secondary and tertiary dentin, which increase the coverage of the pulp. Etiology of pulpitis. Generally four etiology of pulpitis: bacterial, mechanical, thermal, and chemical. Bacterial kinds may caries, micro leakage around the restoration, periodontal pocket, and abscess. Mechanical, first, trauma, acute trauma like fracture or avulsion of the iatrogenic dental procedures. Pathologic wear like attrition, abrasion, and parodontalgia due to the barometric change. Thermal, heat generated by cutting procedures. Second, heat from restorative procedures. Third, heat generated from electrosurgical procedures. And fourth, fractional heat from polishing restorations. Chemical factors: acids from erosion. Second, use of chemicals like monomers, liners, bases, phosphoric acid, or use of cavity desiccants like alcohol. Classification of pulpitis. There are 5 types of pulpitis. Acute pulpitis, mainly 3 types: acute, chronic, and exacerbation of chronic pulpitis. Acute pulpitis divided to the local and diffuse pulpitis. Chronic pulpitis divided to the chronic fibrous pulpitis, chronic hypertrophic pulpitis, and chronic gangrenous pulpitis. Classification by the World Health Organization. First, pulpitis, hyperemia of pulp, acute pulpitis, purulent or abscess of pulp, chronic ulcerative pulpitis, chronic hyperplastic pulpitis, undefined pulpitis, extracted pulpitis, necrosis of pulp, pulp gangrene, degeneration of pulp, like denticles, petrificatis, and abnormal development tissue of tooth, secondary irregular dentin. Clinical symptoms of pulpitis. Firstly, about the acute pulpitis. There are four main symptoms of acute pulpitis. These symptoms we may refer to the or acute local pulpitis or acute diffuse pulpitis. First, long-standing pain arising under the influence of irritants. It means that after action of irritants may arise what? Pain, the sharp pain. Then pain at night. Mostly patient has pain at night. Paroxysmal pain, it means that sometimes painless period, sometimes painful period is present here. And last one, causeless pain. Causeless pain, it means that pain arises without any reason. General symptoms of chronic pulpitis. First, long-term pain after influence of irritants, and after removing of irritants, pain continue. Then pain triggered by hot and cold. Patient usually had a previous history of acute pain in the same tooth. Then dull ache, then hypertrophy of pulp, which you can see in the caries cavity. The pain at night is absent. We should pay attention that if compared with acute pulpitis, there is what pain. There is a dull ache, no sharp pain, and mostly the very important for us for differentiation, the pain at night is absent. Differential diagnosis of pulpitis. Acute local pulpitis, we should differentiate from deep caries, from acute diffuse pulpitis, and from chronic fibrous pulpitis. How can we do it? You know that if we differentiate between disease, we should know that both have to be the same science. Acute local pulpitis and deep caries. After influence of irritants or on deep caries or on acute local pulpitis, there is pain. But when deep caries, after removing of irritants, pain stops. When acute local pulpitis, after removing of irritants, pain continue long time. Then acute local pulpitis, we should differentiate from acute diffuse pulpitis. Because acute local pulpitis and acute diffuse pulpitis have the four main and same science. We said about them, four main science. But how can we differentiate acute local pulpitis from acute diffuse pulpitis? When acute local pulpitis, pain localized on the one area or one tooth, patient may show me that which tooth is painful. But when acute diffuse pulpitis, pain irradiate to the branches of trigeminal nerve. That's why when acute diffuse pulpitis, patient can't show me that where is painful tooth. Then, when we probe the cavity, caries cavity, if there is acute local pulpitis, probing may be painful just on one point, where near to the pulp. If there is acute diffuse pulpitis, probing may be painful everywhere on the bottom of caries cavity, because when acute diffuse pulpitis, pulp is all pulp is in inflammation. Then when odonto electrodiagnostic, when acute local pulpitis, especially on posterior teeth, if you will put on the one place, maybe show me device may show me the normal pulp condition, but another place may show me that there is inflammation, or the odontoblastic electrical major may show me that there is what more than normally. Normal, you know that 6 microamperes. Acute local pulpitis we should differentiate from chronic fibrous pulpitis. The same signs is that or on acute local pulpitis or on chronic fibrous pulpitis, pain arises after influence of all irritants, especially thermical irritants, or hot or cold temperature, changes of temperature. But when acute local pulpitis, there is pain at night. When chronic fibrous pulpitis, pain at night absent. That's why we may differentiate chronic fibrous pulpitis from acute local pulpitis. Then next differentiation, when chronic fibrous pulpitis, pulp chamber is open, but when acute local pulpitis, pulp chamber closed. We can check it with probe. Then when acute local pulpitis, there is castless pain. But when chronic fibrous pulpitis, mostly pain after influence of irritants, especially hot or cold irritants. Acute diffuse pulpitis. Acute diffuse pulpitis we should differentiate from acute local pulpitis, we said about them, from acute periodontitis. Acute diffuse pulpitis we should differentiate from acute periodontitis because the same situation here, or on acute diffuse pulpitis or on acute periodontitis, there is a pain irradiated to the branches of trigeminal nerve, and percussion is painful, or on acute diffuse pulpitis or on acute periodontitis. But how can we differentiate? Is there acute diffuse pulpitis or acute periodontitis? When acute periodontitis, we can meet changing on the transitional fold. With palpation, we can find there the swelling area. But when acute diffuse pulpitis, there is not swelling area because periodontal ligament is not changed. When acute diffuse pulpitis, mostly may arise pain at night, but when acute periodontitis, pain arises all time. Acute diffuse pulpitis we should differentiate also from neuralgia of trigeminal nerve. How can we do it? When acute diffuse pulpitis, pain increase slowly, but when neuralgia of trigeminal nerve, pain increase to the top immediately during the 20 or 30 seconds. That's why when neuralgia of trigeminal nerve, patient says me that I had pain immediately and sharper than normally. Sharp pain. I had sharp pain and immediately. That's with them we can differentiate acute diffuse pulpitis from neuralgia of trigeminal nerve. Acute diffuse pulpitis we should differentiate from alveolitis also. When alveolitis, we have to check the wound from where extracted the tooth. If around the wound there is the gray plaque and empty the extraction area without blood clots, it means that there is alveolitis. That's why we should clean that area and close with some antibiotics or with normal blood clots. Chronic fibrous pulpitis. Chronic fibrous pulpitis we should differentiate from deep caries, chronic gangrenous pulpitis, and acute local pulpitis. From deep caries, we should differentiate because or on deep caries or chronic fibrous pulpitis, tooth reacted to the hot and cold irritants. But when deep caries, after removing of stimuli, pain stops. But when chronic fibrous pulpitis, after removing of irritants, pain continue a long time. Then, when chronic fibrous pulpitis, pulp chamber is mostly open, but when deep caries, pulp chamber is closed. Chronic gangrenous pulpitis. Or on chronic fibrous pulpitis or on chronic gangrenous pulpitis, pulp chamber is open. But if we will check with probe, probing will be painful when chronic fibrous pulpitis on the mouth of pulp chamber. But when chronic gangrenous pulpitis, probing may be painful just on the mouth of canals, because when chronic gangrenous pulpitis, crown part of pulp is necrosis. That's why without any pain on the mouth of pulp chamber. And when chronic gangrenous pulpitis, but smell from the cavity, Chronic fibrous pulpitis we should differentiate from acute local pulpitis also. I explained about them when I explained acute local pulpitis, difference diagnostic of acute local pulpitis. Chronic gangrenous pulpitis we should differentiate. I said about them, I explained chronic fibrous pulpitis, and from chronic apical periodontitis. Why? Because or chronic gangrenous pulpitis or chronic apical periodontitis, the pulp is necrosis. But when chronic gangrenous pulpitis, pulp necrosis partly, and after probing may arise a little bit pain, no sharp pain, dull pain. But when chronic apical periodontitis, or probing or checking with some endodontic tools without any pain, because all pulp is necrosis. That's why tools doesn't react it to probing. Then when chronic gangrenous pulpitis, pain may arise after action of hot or cold stimuli, a little bit pain. But when chronic apical periodontitis, this pain is absent. Then when chronic apical periodontitis, we may check with X-ray examination. After X-ray examination, when chronic apical periodontitis, there is resorption of alveolar bone. But when chronic gangrenous pulpitis, this sign is absent. Hypertrophy of pulp or hypertrophic pulpitis. Hypertrophy of pulp, we should differentiate from hypertrophy of gum and hypergranulation from bifurcation or trifurcation. We should know that when hypertrophy of pulp hypertrophy to the outside or to the caries cavity. How can we check? Is there hypertrophy of pulp or hypertrophy of gum? We should, for it, we should take the probe and move probe around the hypertrophy. If probe stick on one point, it means that there is hypertrophy of gum, because hypertrophy of pulp raise from inside of the tooth. But when hypertrophy of gum, this hypertrophy may raise from gum side and from outside. That's why when with probe we will check, our probe will stick on one point. But the same situation with differentiation with granulation from bifurcation or trifurcation, because granulation from bifurcation or trifurcation also raise from inside of this. How can we differentiate? Is there hypertrophy of pulp or granulation from bifurcation or trifurcation? We have to check it just with X-ray examination. X-ray examination will show me that if granulation from bifurcation or trifurcation, between roots there is the black area, and the black area connect with the pulp chamber without dentin or cementum. That's why we should say that if there is black area around the roots and this black area connect with the pulp chamber, it means that there is what granulation from bifurcation or trifurcation. And then we have to check with clinically also. Next, about structure of periodontum. This is histologically picture of structure of periodontum. We should I will explain you about them, what is the structure of periodontum. There are grown substance the same. Periodontal ligament also is connective tissue and consists of grown substance, fibers, and another cells, blood vessels, nerves, etc. About fibers, there are three types of fibers: collagen, oxytolin, and elastic fibers. If you remember that pulp also is connective tissue, but pulp doesn't have the elastic fibers. In pulp, just collagen fibers, but in periodontal ligament, there are collagen fibers, oxytolin fibers, and elastic fibers. There are the main fiber groups. The very thick fiber group is transseptal fibers. Transseptal fibers connect tooth to tooth, or transseptal fibers located between tooth without alveolar bone, and connect one tooth to adjacent tooth. Then on the near to the crown area, there is a horizontal fibers group. Horizontal fibers group located horizontally. Then near to the horizontal group of fibers, there is alveolar crest. Alveolar crest fibers starts from alveolar bone and finished on the cementum of neck part of tooth. On the middle part of roots, there is obliqua fibers group. Obliqua group located obliquely and near to the middle part of roots of root. Then circular fibers located around the neck part of tooth. Then apical part of fibers group. Apical, there is apical groups of fiber groups located apical area and located radially and vertically. And interradicular fibers group. Interradicular fibers group located between roots on the multiple roots teeth, posterior teeth. Periodontal ligament cells. There are a lot of cells, as fibroblasts, cementoblasts, osteoblasts, osteoclasts, odontoclasts, epithelial cells of Malassez, mesenchymal cells, mast cells, macrophages, leukocytes, and other cells. Blood vessels. The periodontal ligament, there are a lot of blood vessels and arginate. Blood vessels arginate from alveolaris superior and inferior artery, intra-alveolar artery, and periostal artery, which located on the periostum. Nerves. Also originate from there are sensory and motor types of nerve endings. Sensory nerve endings originate from trigeminal nerve, but motor types of nerve endings, autonomous and peripheric nerve system, support the blood supply inside of artery. Explain you about periodontal structure and function of periodontal ligament. As a connective tissue, periodontal ligament also consists of ground substance, cellular elements, bundles of fibers, blood and lymphatic vessels, and nerve endings. About ground substance, it consists of two components: glucosaminoglykans such as hyaluronic acid and proteoglycans, and glycoproteins such as fibronectin. Cells of the periodontal ligament. There are three types of cells: connective tissue cells, resorptive cells, epithelial rest cells, and defense cells. Connective tissue cells, there are two types: synthetic and resorptive cells. You know, connective tissue cells means that fibroblasts, cementoblasts, osteoblasts, the synthetic types, and resorptive types: osteoclasts, odontoclasts, cementoclasts. Epithelial rest cells in periodontal ligament, there is epithelial rest cells of Malasse. And finally, defense cells, means that migrate cells, macrophages, mast cells, eosinophils, lymphocytes, basophils, and et al. This is some pictures about cells. Epithelial cells rest of Malasse form a lattice work in the periodontal ligament and appear as either isolated clusters of cells and interlacing strands. Represent the remains of development Hertwig epithelial root sheath, which is involved in differentiation of root odontoblasts and also secrete enamel-like proteins on the root surface. Arranged in close packing of cuboidal cells, completely surrounded by connective tissue cells, located closer to cementum than to alveolar bone, situated in the periodontal ligament at a distance of 1575 from the cementum of the root surface. As age increases, the epithelial cell rest move vertically and are located mostly in the vertical region in the gingiva. Osteoblasts. Osteoblasts found on the surface of the alveolar bone. Ultrastructure is same as that osteoblast anywhere in the body. Bone forming cells derived from osteoregenerator cells, seen on surfaces of bone, giving an epithelium-like appearance. Shape varies, seen as oral, triangular, and cuboidal. Nucleus is ovoid and euchromatic. Cytoplasm is basophilic because of abundant rough endoplasmatic reticulum, responsible for laying down the organic matrix of bone, including the collagen fibers. Alkaline phosphatase present in the osteoblast is responsible for its mineralization. Cementoblasts. These are the cells responsible for secreting the organic matrix, mainly collagen of cementum, as distinct layer of cells on the root surface, similar to osteoblastic layer but not regular in arrangement. Differs from periodontal ligament fibroblasts in appear near the cementum, less rough endoplasmic reticulum, more mitochondria. About fibers. There are three types of fibers in periodontal ligament: collagen fibers, oxytolin fibers, and elastic fibers. If you remember from pulp structure, we said that in pulp is not there is not elastic fibers. Pulp inside of pulp just collagen fibers type 1 and type 2. But in periodontal ligaments, there are collagen, oxytolin, and elastic fibers. The main fibers group, there are a lot of fibers group. The very thick fiber group is transseptal fibers. Next, obliqua, horizontal, alveolar crest, apical, interradicular, and circular fibers. Transseptal fibers located between teeth and fixed between them, starts from cementum of tooth and fixed to another cementum of adjacent teeth. Alveolo-gingival fibers starts from alveolar crests and fixed to the gingiva. Then dentinogingival starts from cementum of root and fixed to the gingiva. Then alveolar crest starts from alveolar bone and fixed to the cementum of tooth. Horizontal ligaments starts to alveolar bone and fixed to the cementum of tooth. There is also interradicular fibers starts located on the bifurcation or trifurcation of multiple root tooth and located the bifurcation or trifurcation starts from alveolar bone fixed to cementum of roots. Then obliqua fibers located on the middle part near to the apical area and fixed starts from alveolar bone and fixed to the root cementum. And finally, apical area. There are two types, radial types and vertical types of apical fibers. Blood vessels. There are alveolaris superior arginate. This artery arginate from alveolar superior and inferior. Then there is interalveolar artery. This is from alveolaris superior and inferior. This is interalveolar artery and vascularized from the periostal artery, which located on the periost. The main blood supplies from the superior and the inferior alveolar arteries that ascend within the bone, giving interalveolar arteries. These branches penetrated the alveolar bone and entered the pedal space as perforating arteries. They are more abundant in the mandibular posterior teeth than maxillary and anterior teeth. In single rotor teeth, they are found most frequently in the gingival third, followed by the apical third. Nerves. Innervation of periodontal ligament. Small fibers in the periodontal ligament, particularly the A and C fibers. The trigeminal nerve innervates the periodontal ligament through the maxillary nerve of inferior alveolar branches. The majority of the nerves supplying the periodontal ligament pass through foramina on the alveolar bone to enter the periodontal ligament space close to the tooth apex, while others either and via the lateral aspect of the alveolar wall. Periodontal ligament functions. First, supportive, maintains tooth is socket. Sensory, nerve supply, sense of touch. Formative, fibroblasts, cementoblasts. You know that fibroblasts make the ground substance and fibers. Cementoblasts make the new cements. Osteoblasts make the new alveolar bone. Protective, cushion-like action from shock. And finally, nutritive, blood vessels provide nutrients. It was about structure of periodontal ligament. Now about classification of apical periodontitis. The first classification by Lukomsky. There are three forms: acute periodontitis, chronic periodontitis, and exacerbated chronic periodontitis, or aggravated chronic periodontitis. Acute periodontitis divides to phase, serous and purulent phase. Chronic periodontitis, there are three forms of chronic periodontitis: fibrous periodontitis, granulating, and granulomatosis. Next classification by the World Health Organization. First, acute apical periodontitis, next chronic apical periodontitis, periapical abscess with fistula, periapical abscess without fistula, radicular cyst, not specified disease of a pulp of tooth and periapical tissues. Etiology of periapical disease. Most periapical diseases are caused by diet pulps. Most but not all pulpal disease is caused by bacterial invasion from dental caries or less commonly cracked teeth. The remainder are caused by non-bacterial pulpal diets, caused, for example, trauma. The products of bacterial invasion and pulp necrosis imitate most periapical disease. Acute apical periodontitis. Clinical features. Generally rapid onset, acute pain, tooth sensitive to touch, massive swelling. Periodontal stage. The tooth is painful to touch by eating, bite, slifeling of elevated tooth in the socket. Endosseous stage. Intensive pain, constant throbbing, pressing pain. Patient wants to extract the tooth. Strong feeling of elevated tooth. Subperiostal stage, throbbing pain increasing in intensity. The tooth is extremely sensitive to touch, swelling area is sensitive. And submucous stage, decrease of painful symptoms. Apical abscess. Abscesses are caused by virulent organisms and decreased immunologic responses. Apical abscesses are caused by necrotic pulps. Abscess formation suggests that the microorganism responsible is virulent or the patient's immunologic defenses are impaired. Apical abscesses are painful, fever, leukocytes, and neutrophilia are commonly present. As the lesion enlarges, it may penetrate the buccal or lingual cortical plates and expand into the surrounding soft tissue. Such extension may include the floor of the mouth, the palate, the face, and the neck. Soft tissue extension will show the usual features of acute inflammation: redness, swelling, and warmth. Unless a dentist intervenes, the abscess will drain spontaneously, exerting a purulent exudate. About chronical types of periodontitis, there are three forms: fibrous forms, granulating, and granulomatosis forms. Pay attention here when fibrous periodontitis, there is just a widening of periodontal gap. When granulating periodontitis, there is resorption of alveolar bone without fibrous capsula. And when granulomatosis periodontitis, there is also resorption of alveolar bone, but with fibrous capsula. Morphologically, granuloma, chronic apical granuloma, consists of 4 zones. First, infection zone, next contamination zone, next irritation zone, and stimulation zone. Infection zone located near to the apical area and consists of just microorganisms. Contaminating zone, there is microorganisms also, and with defense cells, a lot of defenses as neutrophils, leukocytes, and that's all. Irritation zone, this zone is without microorganisms, just consists of some cells as osteoblasts, fibroblasts, and that's all. And stimulation zone, this is the also without any microorganisms. There is young fibroblasts and another connective tissue cells. You know, we have two types of granuloma, the simple and difficult granuloma. When simple granuloma, it means that granuloma consists of resorption area, exudate, and with just fibrous capsula. But when difficult granuloma, there is also exudate, resorption area, fibrous capsula, and epithelial capsula. Inside of the main granuloma, there is the capsula with epithelium. A. Trochists, B. Apical cysts, C. Granuloma, and epithelial. This is epithelial cover. These types of granuloma very difficult for treatment. It depends on if epithelial granuloma, this one, if epithelial granuloma located near to the apical area, we can treat it. If epithelial granuloma, which inside of fibrous granuloma, located far from apical area, we can't treat this type of granuloma. We need just for surgery, extraction granuloma with a little bit part of apical part of root. This is tooth with granuloma after extraction. Pay attention here, granuloma with fibrous capsula. This is appearance on the mouth, the fistula. A radicular cyst appears clinically like this. And X-ray you can find like that. Usually asymptomatic, slowly progressive. If infection enters, the swelling becomes painful and rapidly expands, partly due to inflammatory edema. Initial swelling is round and hard. Later, part of wall is resorbed, leaving a soft, fluctuant swelling blush in color beneath the mucous membrane. For determining of or acute process or chronic radical cysts, we use some manipulation. We can determine with palpation. With finger, we should palpate the transitional fold, and if there is radicular cyst under our finger, we can feel the hard area. And we should differentiate this hard area, hard swelling area, from tumors. Because if there is hard area, maybe or radicular cyst or tumors, we have to send patient to the laboratory analysis. Just after laboratory analysis, we can say that is a radicular cyst or tumor. Because just with X-ray examination, we can't say that there is radicular cyst or tumor. When acute periodontitis, if you remember from picture, with palpation, we have to feel under our finger the soft pulsation area, and the color of transitional fold may change may be present here hyperemia and redness. When percussion when acute process, percussion may be very painful, very painful. But when radicular cysts and chronic process, chronic apical granuloma, percussion may be without pain or a little bit painful, just feeling. That's why we should differentiate radicular cysts from chronic apical granulomas and acute periodontitis. About osteosclerosis. Osteosclerosis is the result of pressure or damaging long time damaging area on tooth. This is the excess forming of alveolar bone.